treatment options for early triple-negative breast cancer. And so on the program that you have a talk about metastatic triple-negative breast cancer a little bit later. It's one of those areas where I think we have seen, or we are seeing, a dramatic change. And in the last 5 years, we have introduced at least 3 treatments. Each of them reduces the recurrence risk by about 40%. And that's almost unprecedented in oncology, in breast oncology, that you have a number of treatments coming together in such a short period that really starts turning around the clinical course of a subtype that is very difficult to treat. You see probably more triple-negative breast cancer patients than other parts of the world. Again, it's very similar to two parts where Zach and I work, because we have a high. Our population is a high degree of immigration from different parts of the world, and with a very young population that's more in keeping with the non-Western society. So we see a lot of triple-negative breast cancer. We see a lot of early HER2-positive breast cancer, and we therefore can see day to day what difference these new treatments are making. Now, please note my disclosures. When we talk about triple-negative breast cancer, again, it's really important to understand it's not one disease. It's a mixed bag. It's a group of patients that are put together under one umbrella, triple-negative, because they don't have estrogen receptors, they don't have progesterone receptors, and they don't have HER2 receptors. And over the years, we have made many attempts how to classify them. And as you can see here, there are gene expression subtyping attempts. And for example, the Baylor classification, I think is interesting, comes up with 4 different subtypes, 2 basal-like subtypes, 1 immune-activated, 1 immune-suppressed, and mesenchymal and luminal AR subtype. But ultimately, I don't think these subtypes will survive. I don't think in 5 years' time we will pay much attention to this. I don't think they're clinically very relevant. They helped us. They helped us enormously in sharpening our mind when we try to understand how triple-negative breast cancer works, and therefore have allowed us to really break down triple-negative breast cancer into the heterogeneous parts. Where we're heading at the moment, and again, I think that's important, is especially for metastatic triple-negative breast cancer, is a very different strategy. We are more looking at therapeutic strategies rather than at different subtypes. So if you look at the key therapeutic strategies apart from chemotherapy, they're coming through immunotherapy, PARP inhibitors, antibody drug conjugates, AKT inhibitors, anti-androgens, just to start with. All of those therapeutic strategies have either a therapeutic target or even a target population. And for example, if you look in immune therapy so far, and I will tell you in a minute why this is changing, but so far, immune therapy in the metastatic setting was clearly around PD-1 positive patients. PARP inhibitors, again, so far, is for patients with BRCA germline mutations. But again, there are data coming out that patients with other germline mutations or patients with somatic, in other words, tumor mutations, may also benefit. Antibody drug conjugates are probably the most exciting area of development for the next 5 years. The last 5 years were immune therapy. The next 5 years will be antibody drug conjugates. And you see there's a lot of new targets, TROP2, HER2, HER3, LIV1. Now, some of you may say, I've never heard of TROP2, and quite rightly so, because TROP2, from a breast cancer point of view, is actually quite irrelevant. It's not a protein that really drives the cancers in their development, but it is highly expressed on most breast cancers and most triple-negative breast cancer, but also in other subtypes. And so one of the things we have learned, and again, that's important going forward, is that these new antibody drug conjugates, they don't need to target oncogenic drivers anymore. In the past, we developed antibody drug conjugates to, let's say, HER2, big driver for HER2-positive breast cancer. But here, all you need is a protein on the surface, irrespective of what it does, that we use as an anchor for this targeted therapy to come in. And that will allow us to develop many, many more treatments going forward. Now, one key aspect of why we're struggling to classify triple negative breast cancers, that these treatment-derived subgroups are overlapping. You can't say it's a PD-L1 positive patient and therefore everything is clear. In fact, we may do a little bit more what our lung cancer colleagues do. We'll say in the future, is a patient PD-L1 SP142 3%, CPS 15%, BRCA germline mutation, TROP2 high, HER2 1 plus, PIK3CA mutation on androgen receptor expressed. And that I would like to see in a few years' time, because it allows me as an oncologist to really tailor the therapies properly to those patients' needs. But what is very clear is that the gene expression subtypes you see on the left side of the slide are not aligned with the therapeutic subgroups you see on the right side of the slide. And that's just sort of a starting thought to really set the scene what triple negative breast cancer is. Now, a question that often comes up in our MDT and in many other MDTs, do all patients with triple negative breast cancer really need chemotherapy, or is there a really low risk group that may not need chemotherapy? And the answer is probably most patients do need chemotherapy. If you look at smallish tumors, T1, so less than 2 centimeters, no positive, you see in gray survival without chemotherapy, and in yellow survival with chemotherapy, you see a benefit of around 10-12% from chemotherapy. That's clear. It's no positive disease. If you look at T2 and naught, again, you see a benefit of around 7 to 10%, even with the very small tumors. And these tumors should always be considered for neoadjuvant therapy, anything T2, anything node positive. When it comes to T1 tumors, and here T1C, so we're talking tumors as small as 11 millimeters node negative, you still see 7% more patients alive after a few years if they get chemotherapy. You see tumors T1B, 6 to 10 millimeters, still 5% more alive. And these patients, traditionally, we would have said adjuvant chemotherapy. But again, I want to discuss that with you, but at least the T1C tumors shouldn't better be considered even for neoadjuvant therapy, depending on what your local setup is. And if you look at the smallest tumors 5 millimeters or smaller, even in those patients, there is a benefit of adjuvant chemotherapy. And that is something important for us to learn. I have seen patients with tumors as small as 4 millimeters, node negative, who have metastatic recurrence within a few months after their initial disease manifestation. And as these often are young women, my steer would always be to treat rather more intensively than less. Are there any ways of subclassifying those T1 tumors? And again, what I'm sharing with you is research. It's not ready for clinical practice, but I think it's thought-provoking. In the Netherlands, in Holland, until a few years ago, patients with tumors less than 2 centimeters didn't get chemotherapy for whatever reason. That was about 20 years ago. So they have a good database of patients who, with triple negative breast cancer and other subtypes, who didn't get chemotherapy 20 years ago. And what they have now done is they took the initial tumors and looked at how the immune system was in those tumors. Did they have many tumor-infiltrating lymphocytes? Do they have no, or do they have sort of moderate levels of tumor-infiltrating lymphocytes? Under the assumption that if you have a lot of immune cells in your cancer, it may tell you something about pre-existing immunity, about the ability of your body to already react to the cancer. And the data are really interesting. If you look at the average survival, but then put in red, you have patients with low TILs, tumor-infiltrating lymphocytes, and that's more than half of the patients. Then in green, you have patients with intermediate immunity, and in blue, you have patients with very high immunity. Now, what you can see is overall survival with those patients who have high immunity is 93%. That is pretty good at 15 years, but that's only a quarter of or a fifth of patients. Whereas the majority of patients have high risk of disease, even if they already have some immune cells there, and should therefore really be considered for adjuvant or neoadjuvant chemotherapy. Again, if you look at the absolute 15-year survival, 59% with a tumor as small as as well, less than 2 centimeters. That shows you how aggressive these triple negative breast cancers are and why they should be considered for chemotherapy. Now, traditionally, and I would hope that this is changing in most parts of the world, but traditionally we would do surgery and then give adjuvant chemotherapy after surgery to reduce the risk of recurrence. And traditionally, we would only give preoperative or neoadjuvant therapy to those patients who are considered inoperable. Now, this was based, there were many studies about 20 years ago. If you look back at NSABP B18 or B27, old studies that put all patients together, all subtypes. And they showed that your outcome is pretty similar whether you get chemotherapy before or after surgery. And that was why many people stuck to surgery first and then chemotherapy. But what we've learned over recent years is there are two major, I should say, advantages from giving chemotherapy first, even in patients with smaller tumors, which are operable. The first one is we can significantly downstage the cancer. And that, as we've known for many years, facilitates less invasive surgery to the breast. The breast conservation rate goes up. But more recently, we also can do more sentinel lymph nodes, and we can introduce targeted axillary dissection, two things that really reduce the morbidity associated with axillary surgery. Now, what we used to do 10 years ago, let's say do a sentinel lymph node prior to neoadjuvant chemotherapy, and then consider axillary clearance if they were positive after chemotherapy, is something we have moved away from. For example, we have seen that you can do the sentinel lymph node very safely after neoadjuvant chemotherapy, and therefore spare a lot of women from unnecessary, more intensive axillary surgery. The second benefit, I think, is even more pronounced and is obviously affecting overall survival. And that is, we can divide patients into two groups depending on how they respond to neoadjuvant chemotherapy. There's a group of patients who achieve what we call a PAF-CR, and that's the complete disappearance of all invasive cancer from breast and lymph nodes. And those patients have a fantastic outlook, as we have learned. We have patients who have residual disease, and unfortunately, those patients have a relatively high risk of recurrence. Now, these are now old data, but they have been confirmed, meta-analysis data from the FDA. As you can see in red up here, in a couple of Meier curve patients with a PAF-CR, they have a extremely good 5 and 10-year-old survival, near 90%, whereas patients who have residual disease have a 40 to 50% recurrence risk. Most of those recurrences occur over the first 3 to 5 years. The hazard ratio for overall survival being 0.16 if you have a PAF-CR, so highly, highly predictive in triple-negative breast cancer. But this wouldn't be very helpful if there wasn't a way of modifying that risk, because there's one thing telling patients you are high risk or low risk, but the other thing is if the patient then asks, what can you do about it? And we say, well, actually, I can't do anything about it. That's not terribly helpful. So it was really, in my opinion, groundbreaking was the Japanese-Korean study a few years ago that then gave to those patients who had residual disease, they gave them adjuvant capecitabine chemotherapy, and that dramatically reduced the risk of recurrence by nearly 50% with a simple postoperative chemotherapy. And so for the first time, we could modify the risk of high-risk patients, whilst we don't need to modify the risk of patients with low-risk disease. And in fact, giving capecitabine there doesn't really help. So what we're doing now, and what the standard of care should be, patient PAF-CR, not necessarily further therapy. We can talk about immunotherapy in a second. And patients with residual disease, chemotherapy with capecitabine, or offering a trial where there's a lot of work going on. Now, a key question for us, or resulting from this, is can postoperative treatment improve the cure rates in patients with residual disease? And the answer is yes, as I showed you with the CRADE-X data. So these were patients with stage 1 to 3 triple-negative breast cancer who had residual disease after neoadjuvant chemotherapy, got capecitabine, or were just observed. And as you can clearly see, there's a substantial risk of death. There's a substantial risk of recurrence is nearly 50%. So it has become the new standard of care. But there's also newer data now from this year with in this subgroup of patients who have BRCA1 or BRCA2 germline mutation. That's about, as you know, 10-15% of the overall population. And a similar trial design. Again, for me, the most important part here is the neoadjuvant chemotherapy non-PARP-CR and then randomized to a PARP inhibitor or olaparib for 1 year or placebo. And the data, again, are very, very impressive with a more than 40% reduction in recurrence-free survival. Now, the difference between the study on the left and on the right is on the right, it's a higher risk group. On the right, those patients also have now routinely more intensive chemotherapy with platinum, whereas on the left, they didn't. And clearly, even now with more intensive pretreatment, we still introduce a substantial benefit. That is why that is going to be the new standard for patients with BRCA mutations. But the second question is not just can we improve the outcome for patients who do badly, but can we actually increase the PARP-CR rates? Can we make more patients do well before surgery? And one of the big topics has been platinum, whether or not we introduce platinum. Now, it's a little bit like Marmite, as we say in the UK. Some people love platinum, others are a little bit apprehensive. I've been in the platinum camp for a long time because you see a lot of triple-negative breast cancer patients and see what difference it does make. It is also a simple to give, fairly inexpensive therapy most of us can give wherever we are in the world. Now, if you look at the PARP-CR rates with anthracyclines and taxanes alone, they're only around 35%. And please do remember that number 35% for what we're going to discuss in the next half an hour. There are 3 studies that had preoperative chemotherapy with and without platinum, slightly different chemotherapy strategies. And all 3 studies showed a substantial increase in the PARP-CR rates with the addition of platinum. All 3 studies were consistently above 50%, 53, 54, 58% PARP-CR rate. That is very, very impressive. Now, why hasn't platinum be the standard of care in all parts of the world and in international guidelines? And it's difficult to be honest, it's difficult to understand the politics behind it. But one of the reasons was there was limited follow-up data. We have the data from the German study that shows a nearly 10% absolute difference in disease-free survival, which is a hazard ratio of 0.56. So again, more than 40% risk reduction. We saw the American study relatively small, which had a 5% difference, but that wasn't significant. But what's really important is at this ESMO, we saw data from a trial called Brightness, which is the trial you see on the right side. And that also confirmed a more than 40% reduction in recurrences with the addition of platinum, with a more than 10% absolute difference. And I think with 2 out of 3 studies showing a more than 40% improvement, and the 3rd study showing a clear numeric trend, this should now be standard of care. It doesn't just improve PARP-CR rates, it also improves long-term outcome and is easy to give. Now, if we move on to the area of, which is obviously an area that's very close to my heart, but we have seen interesting data in the last few years. There are 2 phase 3 studies with immunotherapy. Our study, Keynote 5-2, is the larger one with nearly 1,200 patients. Our strategy when we designed this trial was very clear. I always said, I want to have the most effective chemotherapy backbone and then see whether I can improve the results further if we add in immune therapy to this or not. And the thought behind there was, I don't want to have a study where I use suboptimal chemotherapy and then we improve the outcome by 10-15%, and someone says, well, you could have achieved the same by just adding in platinum. So this is optimal chemotherapy with or without immune therapy for 6 months prior to surgery, and then carry on with immune therapy or placebo for another 6 months after surgery. 2 endpoints, PARP-CR, short-term endpoint, long-term endpoint, event-free survival, so can we reduce recurrences. A second study, much smaller, 300 patients, Impassion 031. This did not use platinum in the control arm, therefore, what I would describe as suboptimal chemotherapy, but otherwise immune therapy or placebo. Because it was smaller, patients were unblinded at surgery and could continue with immune therapy, but that wasn't blinded. So there's only reliable endpoint we will get is PathCR, the short-term endpoint. If you look at the two trial populations, very similar, although our study, KEYNOTE-522, had more than 50% node positive patients, so a slightly higher risk group compared to the IMpassion031 trial. The data, if you look at it the right way, are remarkably consistent. If you look at the PathCR, it's short-term benefit. We see in KEYNOTE-522, we go up from 51 to nearly 65%. Now, if you think back where we were only 5 years ago, anthracyclines, taxanes, 35%. We pushed it up to 50% with platinum. We push it up to 65% with platinum and immune therapy. That's a dramatic improvement we see there. The delta with the addition of immune therapy, about 30-40%. Similar in IMpassion031, suboptimal control arm, so 10% less PathCR despite having patients with smaller tumors. But again, a 16% increase with immune therapy. So it works irrespective of whether we give platinum or not. But the key question for the last 2 years were, how does this translate into a long-term benefit if we have better PathCR? And we got the answer now. We shared this at ESMO. It's coming out in the New England Journal in the next few days. Is with more than 3 years follow-up, we have a definitive improvement in event-free survival. The hazard ratio is 0.63. We have about an 8% lower 3 years recurrence risk. That's a massive benefit for patients in this population. And if you look at some of the subgroups, on the left side, you see the PathCR rates by nodal status, node negative or node positive. And initially, we felt there may be more of a benefit in patients with node positive disease. But when we look at long-term outcome, as you see in the orange box, there's absolutely no difference. So patients with stage 2 disease benefit as much as patients with stage 3 disease from the addition of immune therapy. What about PD-L1 as a marker? And you will hear later on today, in metastatic disease, PD-L1 is an important predictive biomarker for the benefit of immune therapy. However, in early disease, it is not. Patients derive a benefit of immune therapy regardless whether they're PD-L1 positive or PD-L1 negative. Again, what you see on the left side is the PathCR rates, and you can see that in red is the control arm with negative PD-L1, that's CPS less than 1, or a little bit of PD-L1, that's in the middle, CPS of 1 or higher, or PD-L1 positive, properly positive, CPS of 10 or higher. You can see that the PathCR rates in the control group are going up. So we have known for a long time the PD-L1 expression, which is linked with immune cell infiltrate, is a great predictor of the benefit of chemotherapy. However, it's not, in this setting, a predictor of the benefit of immune therapy. The delta, as you can see in green with patients who received immune therapy in addition, is around 40 to 80%. So we add about 40 to 80% higher PathCR rates, regardless whether patients are PD-L1 positive or PD-L1 negative. And again, if you look at the right side in the orange box, long-term outcome, same benefit whether patients are PD-L1 positive or PD-L1 negative. Now, you may ask, why is this? Because you will hear later on that in the metastatic setting, PD-L1 is an important predictive marker, and you should not give immune therapy to patients with metastatic disease who are PD-L1 negative. Well, the reason is, I think, our theory is quite simple. If you deal with early breast cancer, early triple-negative breast cancer, there's high dynamic in the tumor biology. The plasticity of those tumors is high. In other words, we have data, even in ER-positive disease, where we give immune therapy or chemotherapy, and 2 or 3 weeks later, more than 2/3 of patients who are PD-L1 negative jump PD-L1 positive. And so what you see at baseline may not be reflective. You can actually induce PD-L1 expression, you can induce PD-L1 positivity, and that's probably the explanation why all patients in early disease benefit, whereas in metastatic disease, this is much more fixed and doesn't change that quickly. What about other long-term benefit endpoints? We looked at distant recurrence-free survival on the left side. So this is metastatic disease. You see a hazard ratio of 0.61, massive benefit. And with only 3 years of follow-up, the overall survival benefit is just emerging. Now, if you think about patients who have the recurrence after 2 years and then live for another 18 to 24 months, not all those events have occurred, but over the next 2 years, that will be statistically significant and therefore enhance our message. This is the new standard of care. Really interesting subgroup analysis. That was pre-planned. Is what you see here on your screen. And this is the PCR benefit with immunotherapy still predictive of a survival benefit? And as you can see here, the two top curves are patients who achieved a PathCR with chemotherapy and or chemotherapy with or without immunotherapy. Green is immunotherapy, red again is chemotherapy alone. And then you see the two lower curves are patients who had residual disease at the time of surgery, where you may say actually the treatment didn't work optimally, but with or without immunotherapy. So two things I read out of this. The first thing is obviously outcome of patients with a PathCR is fantastic, and that's 2 out of 3 patients. You see there is still a 2% better outcome for those patients who have a PathCR with immunotherapy compared to those who don't. We've done big studies, affinity for a 2% difference, so that is a great benefit. Hazard ratio 0.7. So we shouldn't say PathCR is the same. Actually, it may be that the PathCR quality is better if you give immunotherapy. A second thing we can read out is if you look at the patients with residual disease, where you may say the treatment didn't work optimally. Well, even if it didn't work optimally, patients still have a massively better outcome if they had immunotherapy. 11% fewer recurrences, absolute, again, hazard ratio in the 0.7 range. So clearly we're changing the biology of those tumors with the introduction of immunotherapy. From a drug development point of view, and this is sort of directed at the FDA, is 2 points. The presence, the evidence of a PCR benefit is and remains predictive of long-term outcomes. So we still can design trials and say if you see a PCR benefit, these patients will be cured better than patients without. But the second point here is an important message. Even if a trial appears to be negative initially, if there's no PCR benefit, it can still turn into a long-term benefit, or we just have to wait longer, and it doesn't rule out a substantial benefit, which is important for some of the trial. What's the toxicity price we pay for the introduction of immunotherapy? Now, here you see the most important side effects during the neoadjuvant phase. Green is pembrolizumab and chemo, red is placebo and chemo. And actually, it looks pretty similar. Yeah, so there's really very little difference in the most common side effects, whether or not we give immunotherapy. What about in the adjuvant phase when chemo stopped? Again, in the adjuvant phase, there's very little difference between patients with placebo and immunotherapy. So it is actually quite well tolerated. If you zoom in and look at the subgroup of side effects we specify as immune-mediated, we can see very clearly these are rare events. We see in the right top corner in the combined phase with chemotherapy, the most common side effects are infusion reactions, which are easy to manage. Patients shiver a little bit. That's easy to deal with. And as you can see, you get this with chemo as well. The most common real immune-mediated side effects is a change in the thyroid function. There was 15% with immunotherapy, 5% with placebo. We see a little bit more rash. We see otherwise pneumonitis, colitis, hepatitis are in the 1 or 2% range and generally very well managed. So it is very manageable, the side effect of immunotherapy, if you know what you're doing. If you look at the bottoms on the left side, the immune-mediated side effects during the adjuvant phase, there's very little difference, again, between placebo and immunotherapy. So the messages here for my endpoint are, it's of course there's a higher incidence of immune-mediated adverse events. This is mainly driven by endocrine side effects and some skin reactions. They tend to occur early in the neoadjuvant phase, very little seen in the adjuvant phase. They're usually low grade. We are now very good at managing them if you know what you're doing with either interruption or steroid administration, or if they're obviously hypothyroid, we need to give them a thyroid thyroxine. And again, it's important as a team that you know what to do, identify these early, and intervene quickly to avoid risk with this. Now, some of those side effects may be irreversible if you look at hypothyroid function, but generally these are easily manageable side effects. And we have lots of follow-up on safety data from other diseases, melanoma and lung cancer, for example, where we know these drugs are safe going forward. Now, are there other studies that looked into this? There's a phase 2 study from the German group, very similar design. It showed a small benefit in the pCR rates, but really interesting data there. If they gave immunotherapy for an induction for 2 weeks prior to chemotherapy, actually they saw much more of a benefit. And these are concepts we are pursuing in research terms. But when they look at long-term outcome, obviously it's a smaller study, they see pretty much exactly what we saw, a reduction in invasive and distant event-free survival and overall survival. Now, what is interesting, this was achieved with only 6 months of immunotherapy because it didn't give the immunotherapy in the adjuvant setting, and that's one of the questions we are still pursuing. Now, there's also one study that came to a different conclusion, and it's interesting to look at this trial. And it's an Italian study called neotrip, where patients received a slightly, what I would call, unorthodox chemotherapy regimen. Carboplatin, nab-paclitaxel, no anthracyclines, and then with or without immunotherapy. And that was given for a long period of time. And if you look at and if patients had surgery, they could have afterwards still the anthracyclines, but it's a little bit late, knowing that the anthracyclines are really immunogenic. If you look at the pCR dates, which is not the primary endpoint, as you can see on the bottom of the slide. In fact, the primary endpoint is event-free survival, which is the right endpoint to look at, because we shouldn't rely just on pCR. But when we presented 5-2, they wanted to show their pCR data as well, and there's still very little difference. And so the question is this a negative trial? Yes or no? The answer is we don't know at this point in time, because we haven't got the primary endpoint, which is recurrences after 5 years, so we need to wait. But it does raise a question about what's the optimal chemotherapy regimen. And we have all trials that use anthracyclines and taxanes with or without immunotherapy have shown a substantial benefit, whereas the trial that didn't have anthracyclines in there and used platinum and taxanes only didn't show that benefit. That suggests to me is if you do want to give immunotherapy at this point in time, stick to the trials we have and don't divert from the regimen that we are using. What the group of the neotrip study has done, we're doing similar things with the larger trials, is looking really at sort of clever biomarkers, how to predict who patients who may benefit. And there's, for example, an immunotherapy score on IO score that tells you are those tumors susceptible to immunotherapy or not. And clearly, even in this negative trial, if patients have the high IO score, they actually seem to be benefiting from immunotherapy in pCR rates. Also, the group also looked at gene expression signatures prior to the start of therapy and see how they relate to pCR, and found out that angiogenesis or fatty acid metabolism are possible predictors of response and possible markers of resistance, in fact. And that's interesting because we can target those pathways therapeutically, and it may be something we want to do in the future. And then they looked at something I find quite neat, is looked at a group of patients who do it amazingly well and had a very early, very massive response. And they called them the super responders, where after a couple of cycles, there was basically no tumor left for biopsy. And these super responders, it seemed to be that they were enriched in the gene expression profiles for immune signaling and immune cells, and you see the exhaustive list down at the bottom of what markers were done there. And it's obviously difficult to work with those data, but what it shows us is with those studies in the neoadjuvant at tissue axis, we will get a lot of insight into who are the patients who benefit or not. Where's the development going? These are the studies you saw. But there's also studies in suboptimal responders where you start the immunotherapy halfway through. I'm a little bit skeptical around that design. because we need to have this release of the antigens early on and to optimally boost and jumpstart the immune process. And we may not have this if we only add immunotherapy halfway through. On the other hand, it allows us to select a high-risk group and that's clinically always good. When we try to design such a trial, one of the problems was that there is no universally accepted definition of suboptimal response, and the FDA and EMA were a little bit funny about that. There are adjuvant trials ongoing, and I get this question often from patients who unfortunately had their cancer taken out by their surgeons and said, can you now give me immune therapy? My answer is always no. Now, I would at the moment only give immune therapy in the neoadjuvant setting, only in the way we did in Keynote 5-2, in no other way. The reason for that is it may work in the adjuvant setting, but actually what we try to achieve with immune therapy, we try to use the tumor to train the immune system to tackle the residual cancer cells. Now, if the tumor is gone, if you have taken the tumor out as a surgeon, how am I able to train the immune system with the help of immune therapy to tackle the cancer? It may work, it may not work. And therefore, we need to wait for the results of ongoing trials, and Passion 030 is one of those examples, to see whether that's a viable strategy. And the fourth strategy we are pursuing is where we gave chemotherapy first. In those patients with residual disease, we then gave immune therapy single agent. These were interesting studies when we did them 5 years ago. I'm skeptical these days whether that's the right strategy, because single agent activity of immune therapy is relatively limited. So my gut feeling is that our own strategy with Keynote 5-2 probably will come out as the optimal strategy, but we need to see what all those studies bring. Where are we heading? Last minute or so. Well, there's still a bit of work to do, obviously. And if you look at stage 1 disease, what I spoke about a lot was stage 2 and stage 3 disease. Stage 1 disease, there's a lot of discussion at the moment about, can we de-escalate treatment options? And you saw the data on TILs, but we're also looking into new treatment strategies, for example, chemo-free combinations, antibody drug conjugates. We're trying to get trials off the ground with sacituzumab, with or without immune therapy, and some of the other new ADCs. And then see chemo-free, how patients do at the time of surgery. If they're path-CR, they don't need anything. If they don't have a path-CR, maybe we still do need to give them chemotherapy. In stage 2 or 3 disease, we probably need to do a little bit of work on tailoring those strategies, but the new standard of care is chemotherapy and immune therapy, provided it's obviously approved in each country. We will look into identifying optimal responders, a bit along the lines of what I showed you for the neotrip study. But the two important questions come after surgery. One is, in patients who have a path-CR, do we really need to continue with adjuvant immune therapy for another 6 months? And at the moment, I would say, yes, you do, because we have data, the hazard ratio of 0.4 and 0.6, a 40% risk reduction with a year of immune therapy. But we can't say whether we would have achieved the same with only the first 6 months. So at the moment, give it for a year. But I think it's a valid question that needs to be tested, whether in path-CR patients, the continuation of immune therapy will help or not. The other question that's really important is, what do we do with the residual disease patients? And even in our immune therapy trial, the recurrence risk was about 1 in 3 after 3 years, which is still unacceptably high. And chemotherapy is probably not going to be a great strategy forward. What I have a lot of hope with is antibody drug conjugates in this setting, sacituzumab, Dato-DXd, T-DXd, ideally in combination with immune therapy. And that's where the research efforts we'll get to. So this is what I think about early triple-negative breast cancer. And I hope you may agree that we've come a long way from taking those tumors out a few years and giving random FEC-T chemotherapy to now having predominantly preoperative chemotherapy, introduction of platinum, 40% risk reduction, introduction of immune therapy, another 40% risk reduction on top of this. adjuvant capecitabine 40%, 50% risk reduction, adjuvant olaparib 40-50% risk reduction. So all of that together have made the treatment much better targeted, but also much more effective. And we're curing now many, many more patients compared to only 1, 2, 3 years ago. That gives me hope going forward. Thank you very much.